it's a sort of pleasure to be following the Secretary of State for Health with a presentation on taking an evidence-based approach. My son, I had a drink with my son last night, and he's being deluged by your Prime Minister with peddling lies on Facebook non-stop about the day in Parliament, spreading division and fear. So I haven't a great deal of confidence, to be perfectly honest, in the executive of this government in telling any truths. But particularly, I'm glad to hear that you're going to be seeing patients from the comfort of your living room. That's delightful and obviously going to solve the problem. So just a couple of facts that if he was here, I would have said to him, just to remind him about things that matter. One is that it's not just GPs. Your government of 10 years has overseen a 46% decline in district nursing. If you look at poverty, the biggest issue, I think, for primary care at the moment, St Matthew's Church in Fulham feeds 3,000 people a week, 2,000 food banks in the UK. The Tussell Trust has gone from giving out 41,000 food packs at the beginning of this Tory government's regime to 1.6 million. And there's been a 19% increase in the last year. So Secretary of State, the place to start in helping people live healthy lives is to address poverty. And I'm really glad Michael Marmot's talking to you later. So I think you were really polite. And Helen's always polite, she's lovely. So I'm going to talk to you a bit about what we can do. Given that I don't think you can rely on policy and politics to solve these problems, we have to start with what we've got in front of us. And we do have a phenomenal amount of resources, and I don't think what he's offering is anywhere near enough. So let's forget that as even helpful. So let's start with the things that get in the way. So for me, and I'm really sorry to those of you that have been students or do see me talk, because some of this is repetition, but it always takes 3 times before anybody hears anything. If you've got kids, you know this. Okay, so what you see determines what you do. So in the good old days, sticks for kids were things that turned hoops, yeah? And in these days, sticks are things that kids turn into guns. Same stick. How you see the world determines what you do. And for me, ideology is one of the most difficult things to tackle, and this government has a particular ideology which gets in the way of us doing the right sort of work. So there are a number of hypotheses that most people hold about general practice. One is that demand is rising. Quick hands up if you think it is. About 30%. We're just meeting it, we can't carry on, and we don't turn people away. Do you turn people away? Maybe. We don't have enough capacity, we need more staff and money. Frequent attenders all have more than one chronic disease. Hands up if you think so. About 30% again. Secondary care shifts the burden onto us. Social care is failing. Okay, those are the hypotheses. If that's the hypothesis that's the dominant logic behind how you change primary care, then the solution to that is primarily more work, certainly more GPs and more money. But actually, I think we just don't really understand what's going on in general practice, and that's what I'm going to share with you today. Because it's really, really hard to sit there and listen to somebody saying, I can tell you how to run your practice, you just need to put in a nice triage system. Really? We'll give you a bit of money over here. So but I'm not going to let you off the hook either, just saying. Okay. So when we look at general practice, we do a deep dive for a week with GPs, and we ask them, if the person in front of you, somebody that you can help, is it a GP appointment or not? And we ask receptionists, are you turning anybody away? It's very simple. And of course, what you see is that 40% roughly of people who are in front of a GP just aren't GP work. And about 15% are being turned away. This is in our practices, the practices we work with primarily in London. Okay, so that's good, because that's more than that. So presumably, if you sort that out, you would turn nobody away, which is fantastic. That doesn't require more appointments. It requires something different. So more appointments is already the wrong solution, just saying. Okay, so here's across a number of practices. You can see we ask them, in terms of your time, how much time do you think you spend on GP work as GPs? And the blue is GP stuff. So if you have a look at this, there's quite a lot of variety within practice, but this is within, if you actually look within practice, here's one GP practice. This person says 90% of who I see as GP worker. This person says 30%. So either the person who's seeing 90% of people who are GP work, either receptionist thinks they're a really good GP, and that 30% GP is a really bad GP. I'm not going to give them any GP work because they mess it up all the time. So that's one hypothesis. Or we don't know what GP work is. We haven't agreed in a practice what GP work is. So how the hell is reception supposed to know? And how the hell are you supposed to know what other people's work is? So the first starting conversation in a GP practice has to be, what do we think the work of general practice is? And when you look at my lovely friend Julian, who died earlier this year, when you look at his work on general practice, you know, it hits all of these. And the danger with some of the ideologies is it's beginning to turn general practice into just biomedical treatment. And it isn't, is it? There's sometimes you're just the right person to hold someone's hand, help them get their kid to school tomorrow, and do the same again next week and say, thank you, well done, you've done a really good job at getting your kid to school this week. Sometimes that's really, really important. The continuity is really, really important. So, but that range, and some GPs are really good at urgent care, some GPs are really good at continuing care, but the first point of work in any GP practice is, what is GP work and what is other people's work? Because at that point, we think, at that point, you can start organising yourselves differently and better. Okay, so let's have a look and see why people turn up regularly in GP surgeries. That's the thing most people say. Would you agree with that? It's sort of isolation and mental health. And people and multiple comorbidities, chronic disease. You might recognise that. That's the sort of thing people normally say. Here's a GP practice. These are people who are turning up incredibly frequently. They're what we call super attenders. And you look at the age profile. They're not all old people. You look at QOF. They're not all comorbidities. They're not all mental health. There's a couple of red ones that are mental health. They're actually not any of that. So what the hell's going on? If people who turn up frequently aren't old people with comorbidities, who the hell are they? This is a real mixed group of people. Let's have a look and see how much those people cost. So this GP practice on the people who turn up 3 weekly or more, is spending £200,000 a year. Why is £200,000 a year on people who are persistently turning up the right way of spending £200,000? That's what they're spending if you do a 10-minute appointment solution. So our job is to say, why don't you try and find out what's really going on in your caseload? Firstly, what's GP work? Secondly, what's our caseload? What's it really look like? Who's turning up and why? And what's the best solution? And design a solution rather than just put in the 10 minutes, because that 10 minutes isn't working. They're still turning up bi-weekly, more than weekly, 3 weekly, they're still turning up, and that's a lot of money. So if you had £200,000 to spend on that group of folk, how many people are there? Not so many. That group of folk, what might you do differently? Okay, so who are these people and who gets access? So the next for me is that if we keep on putting 10-minute appointments for people who turn up frequently, repeatedly over time, there's some people that get nothing. Now, you say that your job is around population health and looking after the health of your whole population. Well, this is a GP practice again. This is age, and this is the number of hours the GPs are spending with those folks. When you look at this age group, they're getting virtually nothing. Now, that's your group storing up your complex comorbidities for later on, isn't it? That's your youngsters. Now, are we telling me that the 7 to 24-year-olds don't have health problems? I don't think so. I've got under 24-year-old kids. They definitely have health problems. They're not going to a GP practice. Some GPs say to me, well, if they don't come, there's nothing I can do about it. Do you know what? That isn't good enough. So the GP appointment system, as it stands, is broken in meeting population needs. The creative ones amongst you are out in schools, are talking to your local counselling services. You're doing amazing things at getting to these folks. But all the time, your workload is here, determined by people who turn up to an appointment of 10 minutes. This will always happen. That will always happen. So you're just going to perpetuate it. You have to start doing something about it yourselves. So when we look at people who turn up frequently, what we find is that 40% of those who turn up frequently are struggling with life. And that's not just having a bad day. I mean, really struggling with life. The sort of lives that you and I would be struggling with if we were in that level of poverty, in that level of domestic violence, in that level of lack of self-confidence and self-worth, people who have no jobs. That's meaningless life work. You recognise this, don't you, from your own practice, I'm sure. But if 40% of people who are turning up frequently are struggling with life, no GP appointment is going to solve that. Back to Matt Hancock around poverty, universal credit, and food banks. So 50% of your income comes from zero attenders and is used by the top 15%. And I just want you to remember that when you think that as taxpayers, the population expects equal access to services. And we've already created a skew. Whether we think we've been part of it or not, my sense is these things are always co-created. We can't carry on doing the work in general practice the way we always have done. Your frequents becoming, when you look at how frequent attenders map out, you have some people that bounce massively. I'm going to talk to you about in a minute. You have some people who turn up frequently who next year won't turn up frequently because those life situations have been solved, but they'll be replaced by other people who turn up frequently. You've done nothing. You've just spent 200 grand on them, but you haven't actually done anything that's helping them shift from frequent to infrequent. And I don't know if you know that, but it's something that you really need to be looking at in your own practices. Start looking at those people. The harder access is the more people who attend frequently dominate. Because they know how to work the system, maybe? The larger the practice, the larger the skew tends to be. But that's an interesting day. I don't know what's behind that, actually. But it's worth knowing what's going on here. Next thing, the people who turn up frequently are not a product of the population's health. So this is a group of GP practices. We're seeing what sorts of people turn up frequently. You get all these slides later, but some of these are mental health, some of these are people with complex comorbidities. What we found is in streets next door to each other with the same population, the dynamic of who turns up frequently is different. Why is that? Why is that? It must be co-created by the practice. You must yourselves have something to do with who comes back all the time. Something you're doing in it. I don't know what it is, but something you're doing is generating that. So it's not just the nature of some sort of anonymous population health data management stuff that the CCG does. It's not about that. It's about how do we choose to meet need? What are we doing about it? And what we know is that, one thing that we do know is that continuity for people who turn up frequently makes an awful lot of difference, but we're not offering that either. So for instance, if you started offering continuity to people who turn up frequently and different sorts of appointments, maybe they wouldn't turn up so frequently. It's just getting underneath things that would liberate. You could wait for Secretary of State to give you money, or you could do some of this stuff that will make a real difference. Let's take another one. Let's have a look at A&E. So the dominant narrative is that people are turning up in A&E because you aren't giving enough appointments, isn't it? Well, that's wrong. And so when the Secretary of State says he's taking an evidence-based approach, I'm sorry, the Treasury is not hearing this story. But this is a better narrative about what's happening. So their narrative is that demand is rising and primary care is failing. But actually, if you look at the evidence, A&E breaches are related to increased acuity. People who turn up in A&E, I don't know if you've been to A&E much yourselves, but you'll know that people who are in A&E are in A&E because they're damn sick. They mostly need to be there. The problems with A&E is that their workforce is targeted towards trauma. I'm totally relieved at one level because my daughter was in a major road traffic accident 2 weeks ago, and the trauma service in this country is bar none. It was absolutely stunning. However, that isn't the bulk of A&E anymore, and we have a workforce that's primarily aiming towards that as their dominant patient model rather than people who've got complex, difficult problems with their breathing or with their walking or with their heart. So one problem we've got is that the workforce isn't right for the sorts of people we're seeing in A&E. The physical design of A&E isn't right for the people we're seeing in A&E, and we're clogged up in hospitals. Why are we clogged up in hospitals? It took me 3 days to break out of the Royal London. They were totally and utterly marvellous. They were run off their feet. And I know how to play the system. I know how to get the extras. I know how to get the discharge notes. It still took us 3 days to break out. And that's ridiculous. And that really, there's nothing they could have done. Doing their round, starting at 8 o'clock in the morning on the trauma unit, they got to us at 4 o'clock in the afternoon. All they were doing was seeing their folk. There just weren't enough staff to go around. So we've got a real issue about what we're doing around flow, around staffing, and also the over-prescription of diagnostics in A&E. So people who come in with tummy ache, going through phenomenal amounts of review that you'd never do in general practice. So that for me is the dominant narrative in A&E. That is not going to be solved by more GP appointments, is it? So why are we doing that then? Why aren't we looking at A&E? Why aren't we reviewing together, primary care and secondary care, what's going on in A&E and why? Why aren't we looking at different ways of organising A&E as well as looking at different ways of organising general practice? It has to be both and, it can't be either or. Okay, so what we know about the primary care contribution to reducing A&E is not about appointments. It's about these sorts of things. It's about active management of people with complex needs, whether some of you have got complex care nurses, etc. Helping people stop tipping from stable to unstable. You know that tip. We all know that of people who've got chronic disease. You do that, don't you? The step change. We all know that care homes need one practice per care home and that those practices really understand that care home's work and those nurses in those care homes really understand how to manage it. We all know that. I go across London to care homes and there are 5 GP practices associated with them. Their referral rate into A&E is astronomical. Why are we doing that? Well, it's a bit difficult to get the GPs to organise differently around this. Sort it out. Other people have done it. Take an evidence-based approach. Why are you sweating the small stuff here? Why don't you just do the stuff that makes your lives and your citizens' lives better? So some things I can be incredibly tolerant about how long it takes to change, and some things, we just know this, just get on and do it. Just sort it out. You can work it out. Other people have done. We know continuity makes a real difference. That's the care home evidence. I'm going to leave it on a slide so you can look at it in case you want to query it later. Right, let's talk about the relationships between the work of general practice and the work of primary care. Okay, so this is a lady who was in a part of London and had a phenomenal turn-up in the NHS. So those are all the services this person's accessing. And this is, and I'm not going to take her entire case history, but I asked the GP to look at the notes. I don't know how much you review the notes of people who turn up frequently in your practices, but if you do, just take a couple of your really high attenders and do a really deep dive. Just take a couple and just list out, as we've done here, what touch points they had. And these are the touch points that are not the GP. The GP didn't have time to put the GP in. It took him 2 hours to do this. So he had to go at this. This is year 1, and this is year 2. That's year 1, and that's year 2. That is someone whose problems are not getting solved, isn't it? And I did it like that because I like pictures. And of course, if we'd intervened here, ambulance number 3 could have been a trigger. Maybe all of this wouldn't happen. And it's not just the cost to the NHS. Can you imagine that family's existence? Taking this person in and out of various NHS services. There couldn't be anything less joined up if you tried. So, when you're thinking about primary care networks and general practice, the issue is, can general practice solve that problem? A single general practice cannot solve that problem. So when we're thinking about people who turn up frequently, we've got the people who turn up frequently who are struggling with life, where you may be able to work differently with your community, where you can change the way you do your appointment system, where you can put in continuity of care, where you can think about your triage, where you can think about what GP work is. And then there's the people that bounce, and they're not the same people, are they? They're different people. So that's where I think primary care networks are really important. So the issue about primary care networks is we haven't got a clue what they're for. And if you don't like the way people behave, it's usually because they're organising around different purpose. So Mac Hancock's structural solution was basically, if you could all just get together in a nice amalgamated team, we could manage the contracts easier. So it's just a big performance management, NHS, make the hierarchy a lot easier. That, for me, is not what primary care networks are about. But because what you have to have in any network, and the name network is it, it's not an organisation, it's not a management structure, and it's not a club. A club is where you have some people in and some people out. I saw on Twitter today that apparently primary care networks are going to be just GPs, and then any other people can lurk around the horizons as second-class citizens. You start treating your partners as second-class citizens, you will never solve that lady's bounce problems. They have to be partners in this with you. But if primary care networks are only about sorting out contracts so we can manage all those difficult GPs who are far too fragmented, then they really, really only want you to be GPs. You start expanding, folk. You get other people into your primary care network, and then they can't turn you into a performance management system, would be my solution. So what's the problem primary care networks are the solution to? So these are some of them when we asked some of our primary care network leaders. Alleviating GP pressures, getting some income, delivering extended hours, sorting out failing and struggling practices. So that's the transactional stuff. That's economies of scale. That won't make any difference to anybody, just saying. That's not going to improve population health. That's going to not make anybody's lives better. Working at scale. Learning and innovation, could be. Delivering complex care, supporting communities to help themselves, getting upstream into prevention, acting as an integrator. Now that's a network. That previous list wasn't a network. That's an absolute organizational hierarchy. That's tame solutions for tame problems. This is about trying to do something radically different together. This is about acuity. This is about those bounce people who can't be seen on their own in a primary care, in a GP practice. So I think primary care networks are around acuity. If you look at high-performing health systems around the world, this is what they've been doing for some time. They've been organising at family practice level around things that a family practice can deal with. And I like the word family because that is how it is. It's together. I'm going to talk to you a bit about that in a minute if I have time. I have to watch my watch. Oh, nearly. Primary care networks at level 2 around the increased acuity where you're starting to bounce. And then the highly specialist carers on the ICS. Okay. So 3 domains. I'm going to stop here. 3 domains of work for primary care networks. You have to look at those people who are frequently attending. Primary care networks should not be spending all their time in their primary care network meetings working out damn contracts and transactional stuff that a CCG can do for you. Don't even fall in that trap. You should be looking at those notes. You should be getting your frequent attender notes together, and you should be reviewing them together and saying, which of these folks could we, if we could solve one of these person's problems over the year, we would have done a good job together. We have to take a person-centered approach. Second thing is you've got to enable robust general practice. i.e. help general practices sort out that system and flow that I was talking about earlier. And the last thing is you have to develop an asset-based approach to health. And that means collaborating with your local communities in a model that I absolutely haven't got time to share with you. But there is a vlog. So I've put it on a vlog on my website, and Helen's grasping our asset-based inquiry. I'd love to talk to you about it. I haven't got time, but maybe another year. Thanks very much.